Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, BBRF's President and CEO. Today, Dr. Katherine Burdick will present Neurocognitively-Defined Subtypes in Bipolar Disorder, a path to more personalized treatments. BBRF is the world's largest private funder of mental health research grants, supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group of 192 prominent mental health researchers reviews each grant application and selects the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the Foundation to fund creative and impactful basic, translational, and clinical research relevant to the whole spectrum of mental health. One reason that research funded by BBRF has had such a great impact is because we do not limit ourselves to one illness or condition. Since 1987, the Foundation has awarded $450 million to fund more than 6,500 research grants around the world across a broad spectrum of brain illnesses, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, post-traumatic stress, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Katherine Burdick. Dr. Burdick is the Jonathan F. Boris Distinguished Chair in Psychiatry and Vice Chair for Research in Psychiatry at Brigham and Women's Hospital in Boston, Massachusetts. She was the 2021 Colvin Prize winner for Outstanding Achievement in Mood Disorders Research and the 2005 and 2014 Independent Investigator. Our webinar will begin with Dr. Burdick's presentation, which will then be followed by Q&A. To submit your questions, please use the Questions tab. Feel free to submit the questions at any time. Following the presentation, I'll ask as many as possible in the time allotted. And now I'm pleased to introduce Dr. Burdick. Kate, the floor is yours.
Thank you very much, Jeff. And I'll note a note of gratitude toward what used to be called NARSAD and now BBRF for supporting my work over the years, and probably many other scientists who have contributed to the field. So it's an honor to be here and a pleasure to be speaking with all of you today. I'm going to be talking about cognition as a tool in the context of bipolar disorder as we think about trying to understand the disease better and formulate better treatments that are individualized to each person. So let's see. I'm trying to forward. I'm having trouble already. There we go. I'm going to start just by a very broad overview of what bipolar disorder is. Many of you are probably familiar with this, but wanted to give an overview first. Bipolar disorder is a major psychiatric disease, which is classified as a major mood disorder amongst major depressive disorder and bipolar disorder. Bipolar disorder is characterized by episodic changes in mood that are considered to be outside of the range of normal mood states, typically marked by mania as well as depression. And so mania is associated mostly with a high state, euphoria, as well as potentially irritability, but it is accompanied by increases and changes in energy, grandiosity, racing thoughts, and sometimes the symptoms during a manic episode can contribute to impulsive and behaviors that are uncharacteristic of the individual. During depressive phases of the disease, people experience changes in their sleep, in their appetite. They report fatigue and lethargy, indifference to things that were once considered pleasurable, sadness, hopelessness, and oftentimes thoughts of suicide. There are two major types of bipolar disorder that are characterized by our diagnostic manual, the DSM. One is bipolar 1 disorder and the other is called bipolar 2 disorder. These two illnesses or subtypes of bipolar illness are characterized or are differentiated really primarily by the extent to which a person experiences mania. So bipolar 1 patients experience what we think of as a full-blown manic episode that is defined by impairment in functioning. So that might mean changes in social functioning or employment. It may mean hospitalization, but the definition of the full-blown acute mania requires functional impairment. In people with bipolar 2 disorder, they have what we call hypomania, which is a less intense manic episode, and it does not impair functioning. And typically what we also see in both of these subtypes of the disease is a depressive state that looks relatively similar between these two. So the primary differentiation between these subtypes is the extent of mania that occurs. Patients fluctuate in between these mood states and are intermixed with periods of relative affective stability, which we call euthymia. And this course of disease is highly variable among different individuals diagnosed with bipolar illness. About 3% of the adult population is diagnosed with bipolar disorder, which equates to about 40 million people worldwide. This is considered common among psychiatric diseases. And less than half of people with bipolar illness describe themselves as having found effective treatments. So that can be partial treatment response as well as intolerability to certain side effects of medications. But we need to do better with regard to treating patients with this disease. On average, it takes about 7 years to get to a proper diagnosis after the onset of symptoms. And this again places people at risk for poor outcomes, inappropriate medications, treatments that aren't specific for bipolar disorder. And again, here, this is a gap in the field where we really need to do better in understanding how we can get to this diagnosis faster and get care to patients as soon as we can. Quite sadly, on average, people with bipolar illness have shorter lifespans by about 10 to 20 years shorter than the general population. And this is largely due to medical comorbidities such as cardiovascular disease, as well as, unfortunately, suicide. The financial burden is substantial. On estimates, we're looking at about $200 billion every year in health and economic burden in the United States alone. So this is an illness that has substantial disability, substantial societal costs, and really, we are still in a position where we know very little about this illness, and new treatments are far and few between. So some of the challenges, I'm going to start with some of the challenges in what's really halted progress or held progress back in bipolar disorder research and care. The three things I'm going to talk about today and give you some examples of how we're trying to address these challenges is the within disorder heterogeneity, the many comorbidities that we see present with bipolar illness, and the dynamic nature of the course of disease. I'll start with heterogeneity. So heterogeneity is built into the way we diagnose most psychiatric conditions, including bipolar disorder. The DSM-4 is our diagnostic manual, and it is basically consisting of a number of symptom checklists that we use to diagnose these illnesses. They are categorical, which means you either have the disease or you do not have the disease. There's no dimensional component to it. And importantly, they're mostly descriptive. So it's asking people how they've been feeling and observing certain changes in behavior. But bipolar disorder does not have a biomarker. There is no blood test for this disease. There is no way of diagnosing it based on brain scans. It is simply not biologically based with regard to how we define the disease. Clinical presentations vary widely among people with bipolar disorder, and the course of illness itself differs substantially from one individual to another. When you look at the left side of the screen, we're looking at the criteria for the definition of a manic episode. This is how we initially diagnose bipolar 1 disorder in the acute mania phase. What you see is the criterion that we utilize for the diagnosis, and this requires criterion A to be present, so either elevated mood or irritable mood with increased energy. plus any 3 of the other symptoms that you see listed. What this means is that a person could come into my office on a Monday morning and report elevated mood, inflated self-esteem, pressured speech, and distractibility, and walk out of my office with a bipolar 1 diagnosis of acute mania. On Tuesday, another person could come in and report irritable mood with increased energy, decreased need for sleep, flight of ideas, and increased goal-directed activity, and walk out of my office with the exact same diagnosis as the person on Monday, but with not a single clinical symptom overlapping. So these 2 individuals are likely very different, not only in the clinical presentation, but the risk factors that are causing the disease for them, and perhaps most importantly, the way they might respond to treatment. We wouldn't expect that they would respond the same way when they're presenting very differently from a clinical standpoint. But what we do in research typically is to lump those people together and to try to identify treatments that work for both of them. In addition to the heterogeneity, there are a number of very common comorbidities in people with bipolar disorder. About half of people with bipolar 1 will experience psychosis during their mood episodes, and the other half will never experience psychosis. About half of bipolar patients will at some point in their lifetime be diagnosed with a substance use disorder, and about half will be diagnosed with a major anxiety disorder. And these are on top of the primary bipolar diagnosis. Childhood trauma is reported at a much higher rate in individuals with bipolar illness relative to the general population, and sleep deficits and disruptions in sleep are reported in almost every patient with bipolar disorder, many of whom report sleep problems even outside of affective episodes. So when they're otherwise feeling fine from an emotional standpoint, sleep continues to be a problem for many patients with this disorder. And finally, medical comorbidities are very common in our patients with bipolar illness as well, predominantly in cardiovascular disease and autoimmune diseases. So all of these things complicate the picture and make it difficult not only to study and to research this disease, but also to treat people who have many different factors contributing to differential outcomes. And then finally, bipolar disorder is defined by a dynamic course. So at any given time, we're able to take a snapshot of how a patient is doing, but the disease is fluctuating. And after the onset of illness, patients are symptomatic about 50% of the time, and we see changes in mood state and polarity multiple times a year for most patients. In addition to the sort of changing course of disease in any individual, what we're learning more recently in the research space is that there may be a cumulative burden of illness that is adding up over time related to the recurrence of mood episodes. What we see is changes in the brain that are associated with loss of gray matter in certain areas of the brain, as well as potential cognitive and functional decline. This is seen in some people with bipolar disorder, and as I'll talk a bit more about the heterogeneity, it is not seen in other patients. But really getting an understanding of what's contributing to that cumulative burden and attempting to stop that from accumulating is a key aspect of the work that we do. So what are we doing to tackle some of these challenges? I'll start with the heterogeneity piece. And what you're seeing on the right side of the screen is a depiction of an approach to classify people in a different way than we have done previously using those symptom checklists that I showed you. In order to use new ways of classifying people, we think about using brain-based approaches instead of symptom checklists. These are brain disorders after all, and so the characteristics that are most important to think about and to define each individual is the way their brain is functioning. We can apply new statistical approaches, which I'll show you some examples of, to try to identify more homogeneous subgroups. So along this figure here, you're seeing heterogeneity within disorders represented by the different colors of individuals. Some of these cross diagnostic boundaries. You see the colors are not specific to bipolar disorder or schizophrenia. but really we're looking at individuals who share common traits, and within any one of these diagnoses, substantial heterogeneity being represented. In order to classify people based on brain function, what we want to do is to think about using dimensional traits that actually assay brain function and that are shared across these different disorders and across people. The hope is that we'll be able to identify more homogeneous subtypes that you see along the bottom, labeled as biotypes in this particular figure, that presumably share more common features of what causes their disease and are more likely within their own group to respond specifically to a given treatment. So the hope is that by identifying these homogeneous subgroups, we can learn about more from the disease and more personalized care can be applied. And then, of course, for the dynamic course of the disease, we need to think about longitudinal studies, and these need to be done at scale, which I'll touch on very briefly at the end of this lecture. So why do we focus on cognition? There are a number of different ways you can assay the brain and how brain functions. You could look at neuroimaging, you could look at electrophysiological waves. We focus specifically on neurocognitive testing, and cognition can be assayed by doing this, using paper and pencil tests or using computerized tests to see whether the brain is functioning abnormally or normally. The reason cognition is so important in this disorder is represented here in this cartoon depiction of the emotion regulation network of the brain. This circuitry is known to underlie the way in which humans regulate their emotions. And this area of the brain up here in green and yellow, the prefrontal cortex, is the house of cognitive control. Intact cognition, particularly in this region of the brain, is necessary to properly regulate emotional responses. And when there's impairment in this area of cognition, regulatory failure occurs. And this places a person at risk for emotional dysregulation, which of course is a core feature of bipolar disorder. It puts people at risk for developing mood disorders, and it puts people at risk for the recurrence of disease after the onset. Another important reason to focus on cognition is because it is strongly associated with functioning in the community. On the left side of the screen, we see the top 10 leading causes of disability in the world. This is a somewhat older figure from the World Health Organization, but consistently when they release their lists of disability causes, we see our major psychiatric illnesses on the top 10. Major depression, bipolar disorder, and schizophrenia are among these, and they sit alongside things like road traffic accidents and war. So these are incredibly disabling conditions. When you look at studies that try to understand what causes disability in our patients with bipolar illness, you might imagine you'd see acute mania and psychosis among those, but typically those components of the illness are relatively easy to treat and short-lived. And so of course, while a person is unlikely to be working at their job because when they're hospitalized for acute mania, we tend to be able to treat that and get patients out of the hospital relatively quickly. But then the expectation is that they can get themselves back to work and function in the community as expected. But what we've learned over time is that many patients with bipolar illness suffer from a persistent cognitive impairment, even after affective symptoms have remitted. So on the right side of the screen, what you're seeing are about 20 studies. This is a meta-analysis of about 20 studies that looked for correlations between cognitive functioning and community functioning. And if you look at the blue line that runs vertical here, anything to the right of it is a study that suggests there is a strong and positive association with cognitive functioning and community functioning. Again, these data consistently show across all of these studies that cognitive impairment is contributing to disability that we see in our patients. And so if we'd like to reach beyond affective remission and really push for full recovery and thriving in people with bipolar illness, we need to address cognition directly. So these are the reasons why cognition is particularly important in this illness. Now I'm going to talk a little bit about what it looks like in these diseases and how we've used it as a tool of brain function. So this is just a hypothetical cognitive trajectory figure where you're seeing what we know about the way cognition develops over the lifespan. If you focus on the black line here, we see cognition improves in healthy individuals over childhood and into adolescence. Sometime late adolescence, early adulthood, it stabilizes. And we don't see much change in cognitive functioning over the adult lifespan. In contrast, in people who later develop schizophrenia, which we see here in the dotted line, you see a cognitive impairment that's present as early childhood. And individuals who later develop schizophrenia lag behind their peers throughout that normal cognitive developmental stage. Just before the onset of their first episode of psychosis, and typically in late adolescence or early adulthood, you see that drop in cognitive functioning that's consistent with what we call the prodrome, and then a leveling off of cognition, but as a stable deficit over the course of their lifespan. There doesn't seem to be a lot of evidence of cognitive decline after the onset of disease, but that deficit is stable. Again, in contrast, we see this gray line representing individuals who develop bipolar disorder. And during childhood and adolescence, it's believed that individuals who develop bipolar disorder show a normal trajectory of cognitive development. It's not until the onset of disease that we expect to see some changes in cognition that are associated with what might be a declining course of cognitive and functional aspects of the illness. Each of these arrows, importantly, is representing acute episodes. So rather than thinking of this as a linear decline or changes because of the diagnosis, it is specifically associated with the number of episodes that occur in any given individual, which, as I mentioned, can be quite variable person to person. So the idea is that something is happening in the brain during these acute episodes that accumulates over time and results in a cognitive decline and functional decline, at least in some people with this illness. What does cognition look like after the onset of the disease when we look at the group level? So here I'm showing you what is a pretty typical study in comparing patients with schizophrenia, patients with bipolar disorder, and healthy controls on a number of cognitive domains. So I'll first highlight which domains we're talking about, and these will be repeated throughout the lecture. Processing speed, attention, working memory, verbal learning, visual learning, reasoning and problem solving, and social cognition. And these, as I mentioned, are captured using pen and paper tests as well as computerized tests. In this particular study that we published almost 15 years ago now, we took a group of healthy individuals, which you see along this blue line here as performing in the average range. The average on this vertical scale is 50 with a standard deviation of 10. So that means if you have a score of 40, you are approximately 1 standard deviation below average, with the average score again at 50. The red line are people with bipolar 1 disorder who are remitted at the time of the assessment, and the green line are people with schizophrenia who are in the residual phase, so in relative remission, both patient groups. There are two things I want to highlight here, and the first is the qualitative similarities between the groups of patients with schizophrenia and patients with bipolar disorder. So the shape of these lines are very similar, which suggests the kinds and types of deficits that we see in these patients are similar to one another. But the other thing I want to highlight here is that the severity of the impairment is consistently different between these two illnesses when you look at these at the group level. Many studies have done this and have shown that while patients with bipolar disorder show deficits of about 1/2 to 1 standard deviation below average, patients with schizophrenia fall closer to the 2 standard deviation impairment level, much more severely impaired than patients with bipolar disorder. But I've mentioned that there is an enormous amount of heterogeneity in the expression of this disease. And these kinds of analyses, when you lump all of the bipolar patients together, all of the schizophrenia patients together, fail to take that into account. So this is where these new classification approaches come into play. Now, this is the first paper we published on this, again, about a decade ago. where we utilize a statistical approach called hierarchical clustering analysis. The details of the statistics and the way we do this is not important for the purposes of this talk, but what the approach allows us to do is to look empirically at the data. We put in data from each person who we've obtained cognitive performance and cognitive profile data from into the statistical program and simply ask the question, are there groups that hang together based on the way their brains function? Or does everybody look like this red line? If all patients within our sample had a similar profile to one another, the answer to this statistical analysis would be a single group is best representative. But in this case, what we found was the solution implied that there were 3 discrete subgroups that had very different cognitive profiles from one another. And I'll walk through the results here. The first subgroup we labeled as intact, cognitively intact, and that's this purple line that you see here. Relative to the black dotted line, these individuals show no impairment. So there's no cognitive impairment on any of these measures relative to that average performance. And in fact, this group of participants performed significantly better than healthy controls on at least one social cognition measure in our battery. A second subgroup of about 30% of the sample is noted here with the red line, and we labeled them selectively impaired. And that is because the deficits that we see are selective to certain aspects of cognitive functioning. So these deficits are in the mild to moderate range and are really quite specific to things like processing speed and attention, as well as social cognition. But this group of people are performing in the relatively average or even above average range on other measures of cognition. So a really specific cognitive profile. And the last group that represents about 40% of the sample are what we label globally impaired. And these are individuals in the blue line who show deficits across all cognitive domains at a relatively severe degree, so around 2 standard deviations below average. And what I want to highlight here is this yellow dotted line are these patients with schizophrenia. So what this is really showing you is that there's a subgroup of patients with bipolar disorder who perform very similarly to patients with schizophrenia, and there's a subgroup of patients with bipolar disorder who perform very similarly to healthy controls. All of that information is lost when we look specifically at the group level. So what this study illustrates is that there is within disorder heterogeneity. It also illustrates cross-disorder overlap, that there are not so many differences between some patients with bipolar disorder and patients with schizophrenia. It also shows that we're able to identify homogeneous subtypes based on brain function. So rather than using those symptom checklists, we're interested here in how these patients hang together as a group based on the way their brains function. But the important next question is, can we use this approach to tell us something new about the illness itself? And this is where the next study came into play. And the data that I'll be presenting moving forward is from this second cohort. It's an independent cohort of patients with bipolar disorder, collected a larger sample, and we did very deep, what's called deep phenotyping, looking at many different traits, clinical interviews, clinical symptoms, diagnoses, a number of cognitive measures, in order to try to really characterize these subgroups. First, to replicate the subgroups, I should say. And what you see here is a general replication of this, with the solution again showing that there are 3 discrete subtypes based on cognitive profiles within this new cohort of patients. But importantly, we wanted to understand what are the characteristics of this group that are doing so much better than this group? And what are the characteristics of this group that are actually predicting that poor outcome that we're seeing in these individuals? If we can see group differences here, we might be able to leverage those to think about how we can modify the course of disease to promote optimized outcomes for all patients. So we simply characterize these patients and we compare these groups. I'm going to first highlight over here on the left side of the screen the ways in which these groups do not differ from one another. So these subtypes as you'll see, have slightly different labels. We refer to this as the intact subgroup. In fact, they're above average on several aspects of cognition relative to healthy people. There's a suboptimal group that again is showing deficits of about half to 1 standard deviation. And then again, there's a third group that are more globally impaired with deficits hovering closer to 2 standard deviations below average. The things that don't differ between these 3 subtypes are basic demographics. Perhaps surprisingly, bipolar subtype is distributed evenly throughout these groups. The presence of psychosis history is also distributed evenly, and current mood symptoms are similar across these 3 subtypes. Age of onset is similar, and importantly, as I'll note some differences in course of disease, the illness duration is similar. So each of these groups have been ill on average for about 20 years. So they're well into the course of the disease at the point of assessment. Medications don't differ among these subtypes either. So not classes of medications, things like, are you taking lithium? Are you taking anticonvulsants? Nor is the total number of medications different between these groups. So these are the things that don't seem to be driving differences in the outcomes that we're seeing here. As I walk you through the things that do differ between these subtypes and that we think about as potential modifiable treatment targets, I'm going to reference back to this trajectory that I showed you earlier. And the first thing I'm going to focus on is comparison of this phase of life. So we're able retrospectively to assess how people have done premorbidly and in their early life to see whether there are early life risk factors that contribute to their outcomes. And like we see in this particular hypothetical figure, that gray line, you see a premorbid cognitive functioning that is normal, looks similar to healthy controls. When we look in the full sample of bipolar patients, all of them lumped together, and compare them with our healthy controls, we indeed see no difference in premorbid intellectual functioning. So this again is consistent with what we would expect based on this model. However, when we look at our subgroups and we actually address that heterogeneity that I've tried to outline as being so important, we see very clear differences, with that intact subgroup having above average premorbid IQ. This middle suboptimal group is showing average IQ prior to the onset of disease. And really importantly, unexpectedly, we see this subtype of bipolar patients who are showing clear evidence of impaired premorbid IQ. And in fact, the level of impairment that we see in that subtype is very consistent with what we see in schizophrenia. When we look at other early life risk factors, we see a similar picture, with this impaired subgroup having lower levels of education than the other 2 subgroups. We see higher reports of physical abuse during childhood in that subgroup, really emphasizing here that while the model suggests normal neurodevelopment, when we look at the group level, that may be true. However, when we're able to address heterogeneity and look at these subtypes, we can identify a subtype of patients that seem to have more neurodevelopmental factors contributing to their outcomes than we would have expected if we hadn't addressed this heterogeneity. Now I want to turn to this critical period where we expect to see change and cognitive decline as well as functional decline in many patients with bipolar disorder, and look at factors that contribute to outcomes after the onset of disease. First, when we do a proxy measure of decline, and we simply ask the question, does it look like bipolar patients show changes in cognitive functioning between premorbid functioning and current functioning, remembering this is about 20 years into the illness for most of these patients, we're able to do a proxy subtraction and estimate what we think might be the decline that had occurred in those individuals. And what we see when we do this is basically no difference between our bipolar group and our healthy controls. So there's very minimal change in cognition, and it isn't different in bipolar disorder than in healthy controls. This is actually interestingly consistent with about a meta-analysis of about 20 studies that are longitudinal studies that are actually looking at the course of cognition over a period of time in patients with bipolar disorder. And this meta-analysis shows that there is no evidence of cognitive decline in bipolar disorder as a group. what I'm referencing here is anything to the right is actually improvement in cognition over time. And in the left, you see a handful of studies that show mild decline over time. Overall, this meta-analysis reported no evidence of cognitive decline in bipolar disorder. Now, remember that these are relatively small samples, and importantly, none of these studies accounted for the heterogeneity in this illness. So what do we see in the cognitive decline metric when we look at our subtypes? We see a different picture. We see that there's a subtype, that intact group, that actually shows slight improvement in cognition over time. That middle group shows a slight decrement over time in individuals, a loss of a bit of cognitive decline, but not substantial. And again, there is one subgroup, this impaired subgroup, who's showing evidence of about a loss of about a half a standard deviation of cognitive functioning over the course of the disease. So these data suggest that some patients with bipolar disorder show a declining course and some do not. And when we look at the picture at the group level, the assumption here is that patients do not decline. So these data taken together led us to a sort of revised model of trajectories, making the assumption that not only are there cognitive subtypes, but there's probably subtypes based on trajectory over time. And so what we propose here in this new hypothetical model is that there are 3 different trajectories. There's a subgroup of patients who will show normal to supernormal premorbid IQ, and that they remain resilient and they recover after mood episodes and their cognition does not change over time. There's another subgroup who shows normal premorbid IQ and early cognitive functioning, but shows some evidence of decline over time after the onset. And I'll talk about what we see that being associated with. But there's a third group that we and others likely would not have expected, which looks more neurodevelopmental. These are individuals who show lower premorbid IQ and additional cognitive decline after the onset of disease. So really the important thing to highlight here is that this is a window of opportunity for prevention and intervention so that we can try as best we can to get all patients on this trajectory and really to optimize outcomes for everyone. In order to do that, we need to identify modifiable risk factors that differ between these groups and see where we might be able to intervene to correct that. So these are some of the factors that are believed to be modifiable that seem to be contributing to these differential outcomes, at least in our cohort. First, I'm going to talk just about the recurrence rate that we see within these groups. So as I presented in the hypothetical model, the assumption is the more manias and more severe depressions a patient has, the more likely they are to show cognitive decline. And our data suggest that this is the case. We do see in that cognitively intact subgroup the lowest number of prior manias relative to these other 2 groups. This suboptimal group, the red group, has the highest recurrence rate of mania. In contrast, depression looks different. So the depressive episodes we see are actually the highest in that intact group of patients, though I'll note that these differences by group are not statistically significant. So the course of disease seems to be different, and it certainly does contribute to the evidence that acute mania is contributing to a cumulative effect on the brain with regard to cognition and potentially functional outcomes. When we look at comorbid diagnoses, so these I should point out are lifetime diagnoses. These are not current, so the patients at the time of assessment were not currently meeting criteria for substance use. And this is important particularly because what we see here is that, again, that intact subgroup has the lowest rate of comorbid substance use disorder diagnoses, higher in both of the cognitively impaired groups, particularly in that suboptimal group in the center. Anxiety disorders, comorbid anxiety disorders are seen at a high rate across all 3 groups at about 50 to 55%, but these don't differ by subtype. When we ask patients to complete questionnaires about their sleep quality, what I want to highlight here is this dotted line is the cutoff on the scale for poor sleep, and anything above it indicates substantial sleep complaints. So as I pointed out, most patients with bipolar disorder will report significant sleep quality reductions, But within our subtypes, we see substantially more sleep problems in those two that are cognitively impaired relative to that cognitively intact group. So when we think about recurrence of mania, substance use disorders, and sleep quality, all of these are behavioral factors that are modifiable, things that we can target for treatment, and things that we should be considering targeting for treatment directly in order to optimize outcomes in these individuals. I'm going to move to the last part of the data portion of the talk, which is to focus specifically on biological factors that might both be modifiable treatment targets and might differ between these subtypes. So one of the strongest hypotheses from a biological standpoint in the field at the moment for bipolar disorder surrounds the idea of inflammation or immune dysfunction. And I'm not going to go into detail on this slide, but rather we'll just walk you through the model of what we think might be happening in the brain that causes a cumulative burden in the disease. So the idea is that each time a full-blown manic episode, and in many cases severe depression occurs, the body undergoes a massive amount of stress. The stress response provokes a number of molecular changes in the periphery that we believe to be also affecting the brain. These include downregulation of certain neuroprotective factors, as well as upregulation and expression of what are called pro-inflammatory cytokines. These mark inflammation when you have COVID or a flu or any illness, anything that's attacking the body, your inflammatory system activates. And this is necessary for survival. And probably not surprising that we see this kind of response in the body during acute mania and very severe depression. These are incredibly stressful states. Those changes that occur during those acute episodes are thought to then recover and return to normal when a person becomes affectively stable or euthymic. And you see again an upregulation of these same molecular markers during depression, some changes again during next episode, stabilization during stable periods. But over time, during late phases of the disease, after repeated episodes, those markers that are elevated during acute periods don't return completely to normal, even when affective stability is achieved. So again, consistent with what we think about the cumulative effect in the brain itself, we see a cumulative burden of inflammatory markers over time, such that after repeated episodes of the illness, somewhere arbitrarily to some degree around 4 or 5 episodes of mania, we see an incomplete recovery of molecular markers in the blood. They indicate chronic but low-grade inflammation that doesn't recover. And we think that these are consistent with changes in the brain at the structural level and the functional level over time in this disease. So again, if this model is correct, the ability to target inflammation would allow us to stop the decline that's associated with the cumulative burden of this disease. So I'm going to give you one example of one of these markers that we have tested in the blood. And the blood is collected at the same time that we did those other detailed assessments that I've described to you already. The example I'm giving here is a molecular marker called tumor necrosis factor alpha, or TNF alpha. This is a key component of the innate immune system, so it activates in response to pretty much any insults to the body that, as I mentioned before, sicknesses, injuries, and so on, including mania and depression. So there are a number of studies that have shown elevations of this marker in the blood during acute mania and in acute depression. And early in the stages of this illness, we see recovery so that TNF alpha goes back down to normal levels, similar to healthy individuals, when a patient is affectively stable. But later in the disease, we see this is one of those markers that remains elevated, even during affective remission. So given this, we would expect the elevated TNF alpha in the blood would be associated with cognitive decline in our participants. And this is a bit of a busy slide, so you can largely ignore the image here, but we published a paper about 3 years ago now that showed exactly that. What this statistical model is showing you that the number of psychiatric hospitalizations, or the number of times a person has been acutely manic or acutely depressed, is directly impacting how they're currently functioning from a cognitive standpoint. And what we were able to show in this study is that in the blood, peripheral markers of this TNF molecule mediated this relationship between hospitalizations and cognitive impairment. What this suggests is that TNF alpha and its related soluble receptors may be a treatment target in an effort to, again, put someone on a trajectory of resilience over the course of this disease. But importantly, relating back to the heterogeneity of the disease, not all patients with bipolar disorder in this cohort show elevated TNF alpha. So here are the subtypes I'm showing you here again. This black dotted line are control levels of this molecule in the blood. And at the time of assessment, we see that this intact group are actually lower than average on this inflammatory marker, while these other two are elevated, particularly this red group in the middle, suggesting that not all patients show this level of elevation of at least this particular marker, and that inflammation is really only a treatment target in some patients with bipolar disorder. This is particularly important because there have been at least early studies in depression that show if you give an anti-inflammatory medication to try to treat depression, it only works if you give it to people who have elevated inflammation at baseline. If you administer an anti-inflammatory to someone who does not have inflammation at baseline, it can actually make the condition worse. So very important, again, to kind of identify who this treatment works for and when to use it. So just to give a sort of summary of what we've learned about these particular subtypes. Now, again, the subtypes are based specifically on cognitive profiles, but the goal was to understand how can we optimize outcome for those individuals? And does optimizing outcome look different for one subtype versus another? This is where we get to the idea of precision care or personalized care. When we look at that intact subtype, they're the ones who are doing by far the best from a cognitive standpoint. They show no evidence of decline. They show relatively good sleep, low levels of substance use disorders. But interestingly, this group is characterized by the highest recurrence rate of depression, and their suicide attempt rate is 3 times that of this impaired subtype. So perhaps cognition is not the target in this subtype, but rather depression and suicidality may be more urgent areas of intervention that are needed to optimize outcomes for these individuals. These people also would be much less likely to respond to anti-inflammatory approaches as their levels of inflammation appear to be normal. The suboptimal subtype, in contrast, is characterized by some evidence of cognitive decline, not substantial, could still be an area of targeting, but really their profile is characteristic of high rates of mania, poor sleep, and the highest rate of substance use, all again being potential targets of treatment to optimize outcomes in this group. They also show the highest level of inflammation, so may benefit from strategies, perhaps not just medications, but other strategies that reduce inflammation, like diet and exercise. This impaired subgroup is the one that shows the clearest premorbid impairment, but also the greatest evidence of decline. So cognition is certainly a target that needs to be treated in these individuals. They show poor sleep. They have higher rates of anxiety, and again, elevated inflammation. So really trying to emphasize here that by looking at the heterogeneity, addressing it and subtyping these groups based on brain function, we're able to identify differential treatment targets that we think might benefit those individuals more specifically than we would if we were looking across the entire cohort. And I'll just end on the sort of next steps in thinking about that issue around the dynamic nature of this disease, because I haven't touched on that very much. And this is just to note that it's incredibly important to study this disease in a longitudinal manner. All of the data I showed you was cross-sectional. The proxy measures and the retrospective assessment of these individuals allow us to infer certain things, but none of this has been validated in longitudinal studies. And in order to do that, we need very large cohorts. That is in large part because of the heterogeneity. And there are efforts underway now that are contributing to this effort. There are global efforts really to collaborate and to share data across investigators. I highlight the global bipolar cohort here, who are sharing data, mostly existing data, in an effort to understand the disease better. And another initiative that I'm involved in the leadership of that is a new nonprofit foundation focused on funding specific studies in bipolar disorder, including an integrated network, which is a prospective longitudinal cohort of 4,000 patients with this illness that will attempt to uncover information about trajectories of disease and, again, inform these kind of subtyping approaches and personalized care. So just to conclude, bipolar disorder is a dynamic, complex, and heterogeneous condition. Cognitive dysfunction is common and disabling in many patients, but not all patients with bipolar disorder. We can use and leverage this heterogeneity to tell us something new about the illness beyond just cognition itself, and really look to identify modifiable treatment targets. There are many factors that contribute to good versus poor cognitive and functional outcomes in our patients with bipolar disorder, and some of these represent modifiable treatment targets. One of the more obvious things, of course, with the treatment of this illness is episode reduction. That's often the goal of your typical clinical care, is to reduce the onset of new episodes and to remain stable as long as possible. But other areas have garnered less attention, including sleep, substance abuse interventions, and perhaps some newer novel approaches, including anti-inflammatory treatments. Overall, the goal of the work that we're doing is really to identify those individuals who are at greatest risk for poor functioning, trying to intervene to optimize outcomes for every single person who's living with bipolar disorder. And just to kind of end on a note of, I think, optimism, through increased collaboration and long overdue dedicated resources, there are multiple new global initiatives that I believe will promise to move the needle on this complex disease. I want to thank my team, many of whom are seen here, many historically not seen here, and a multitude of funders for the work that I do. Thank you.
Thank you, Kate. What an excellent presentation. Really very interesting and important work that has potential to really have an impact. I think feeling optimistic about where this is going to go makes a lot of sense. For somebody who is listening now, and maybe they themselves just were diagnosed or a loved one was just diagnosed, what should, based upon what you just described, what should they do in the here and now? What steps should they take?
Yeah, that's a great question. You know, I think the answer is both simple and complicated. The simple answer to this is healthy living, the same way any one of us would support longer lives and healthier brain function, things like diet, sleep, exercise. These are not easy things for us to follow, no matter what our diagnosis or lack of diagnosis is. But these are probably the things that are best preventative of changes in cognition, of poor outcomes. Some of the obvious things around reducing substance use, and again, I think stability of one's routine and schedule. These are more straightforward. We don't have a magic bullet yet in terms of preventing or even intervening on the cognitive changes. What we know is what I showed you really here today, and across the field, I think there is some promise around newer medications and such, but we're not quite there yet. So I think that the answer is healthy living.
Well, it's a good answer and an important one, and these are steps that could help all three of the subtypes that you've described. I want to ask you about the important issue of suicide prevention And I thought it was particularly important highlighting the highest risk. Obviously, all groups have a risk, but the highest risk in that intact subtype. What, could you speak a little bit about how people can assess that risk and what they should do once they have done that assessment?
Yes, so it's an incredibly important topic, and as you know, and I'm sure many of the audience members know, bipolar disorder among our psychiatric illnesses has the highest rate of completed suicide, and it is an urgent issue to address. I think, again, a complex one. That particular subgroup is the one that's characterized by the most depression. And so I think that's probably a byproduct of that rather than a byproduct of the cognitive profile per se. Saying that, I think the importance of assessing suicidal ideation, suicidal thinking, and any traits that make a person at greater risk for potentially acting on suicidal thoughts is incredibly important, and something I think most good clinicians do on a regular basis. That said, I think that the state of healthcare and psychiatric care in this country is not optimal, and people wait for long periods of time to see doctors. They tend to see their own clinicians, therapists, less frequently than perhaps would capture this important risk factor. I think there are some promising approaches emerging from the ability to gather information from smartphones, from wearables, that will do a better job of identifying changes in mood, changes in sleep, and changes in other behaviors that might predict, at least to some degree, a higher period of risk for suicide. And so I do think research is contributing to that space. I think the other thing I'll comment on there, which is really important from the standpoint of bipolar disorder, I alluded to the idea that acute mania is relatively easy to treat. That is not, of course, always true for all people, but from the repertoire that we have of interventions, our anti-manic drugs are far better than what we have to treat the depression and the disease. There is a major, major gap in care for depression within bipolar disorder. Most people on in the audience probably also know that in bipolar disorder, there's an added risk of inducing mania in individuals with this disease when you administer antidepressants without a mood stabilizer. That risk has contributed to the complexity of treating depression in bipolar that is harder to do than in people with major depression in most instances. And so I think this is just an area that the field needs to double down on and think very deeply about how we can move the needle on the depression piece of this illness.
Excellent and important points. Kate, I want to thank you for your presentation today. More importantly, for the ongoing work that you and members of your team are doing to help figure this out, which will make a difference in so many lives. Thank you so very, very much.
Thank you for having me.
I also want to thank everybody who joined us today, and I'd ask people to please consider making a contribution to BBRF today. 100% of every dollar donated for research is invested in our research grants. We're able to do this because our operating expenses are covered by separate foundation grants. This means that when you donate $1 for research, that dollar goes directly to the scientist. To make a gift, please visit bbrfoundation.org or call us at 1-800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it, please visit the events and webinar page on our website. I'd like to invite people to please join us again on July 9th at 2 p.m. Eastern Time, when Dr. Kimberly Chu, an associate professor of psychology at the University of Denver and director of the Motivation, Affect, and Cognition Lab, will present motivational modulation of cognitive control in ADHD. Once again, thank you, and remember, together we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives. Thank you.